I think sleep is such a key issue. We discuss it at every clinic visit. And so it's a great topic, and I'm eager to hear what he has to say, as I'm sure all of you are as well. So Dr. Duker, have at it.
Great. So thanks for inviting me, and I'm really excited to get a chance to talk with you guys. Ultimately, Maureen's right. This is something that affects almost everyone. And so I think it's a good topic to go over. Let's see, I just need to share my screen. I'm going to have a PowerPoint presentation, but really I want it to be interactive. If there are questions that you have, as Julia was saying, you can put them in the chat if you think you might forget them, or if you think they're pertinent to what's I'm talking about right now, feel free to interrupt. It's totally no problem at all. There will be a good portion of the time afterwards that I've set aside for questions. So this PowerPoint and sort of the whole presentation part will only take maybe a half an hour at the most. So there should be lots of time for other questions. All right, so I want to share this one. All right, can you guys see the screen okay? If someone could just say yes.
Yes.
Okay, perfect. All right, so this is a view of the Gardner Neuroscience Institute at night, which I thought was appropriate for our sleep talk. Beautiful sunset in the background. I saw a sunset from our clinic building the other night with one of the UC buildings in the background with smoke coming out, and it looked like a nuclear holocaust with the smoke coming out of the smokestacks and the sunrise going behind it. But yeah, beautiful sunsets. All right. Now I'm going to advance. So what is sleep? Well, the author, William Golding, this is the guy who wrote The Lord of the Flies. William Golding said that sleep is when all the unsorted stuff comes flying out as if from a dustbin upset in a high wind. And then this is a video of a dustbin or trash can being blown down the street in Southern California, which I thought was a funny video from the internet. But what does sleep really do? So there's actually some new research on the purpose of sleep. The glymphatic system. So this is different from the lymphatic system, but essentially the glymphatic system is the system that helps to clear metabolic waste and other things from the brain. And we've been able to look at this on an MRI scan using techniques by injecting contrast into the spinal fluid, which is a pretty sophisticated technique. And by doing so, we can see what happens in the glymphatic system during sleep and kind of get these pictures of the removal of wastes from the brain during sleep. And it's been, a question for a long time. What exactly is the purpose of sleep? And this is the first hint that it's potentially a way for our brain to get rid of the bad things that kind of accumulate during the day, and to sort of clear out and refresh for the next day. It's pretty obvious that if you don't get sleep, bad things happen. You can actually die if you are kept up for a prolonged period of time. Sleep is critical for our brain function, and this is one of the first indications as to why that happens. It does seem that the glymphatic system is altered in a number of neurodegenerative diseases, Parkinson's disease certainly included, as well as Alzheimer's disease and other diseases. And so this may be one of the many parts that could contribute to Parkinson's disease and its pathogenesis. So this was the part that I was going to have a poll. I was curious how many of the people that are on the conference have had a problem with sleep, or actually maybe it'd be easier to ask, is there any patients or caregivers that have not had a problem with sleep? Um, but yeah, no, I mean, I think ultimately every person that I ask in clinic does have some problem. When we do kind of surveys, sleep disruption is one of the most common non-motor complaints in Parkinson's disease. It affects between 60 to 98% of patients, so almost everyone. But the reasons for sleep difficulty or lack of sleep are many, and we're kind of going to go over a number of different possibilities in this presentation. It is important to know that if you don't get good sleep, and I don't have to tell you guys this, I'm sure you know, if you don't get good sleep, the next day your Parkinson's symptoms are definitely worse. Whereas if you do get a good night's sleep, it really makes things a lot better. So I've got a series of things that we hear from people in clinic, and different causes for sleep difficulty and the potential causes. And so one of the things that we hear in clinic is, I seem to fall asleep fine, but I tend to wake up in the middle of the night, and it's often not clear, what causes the awakening. Is it something that they have to go to the bathroom? Is it some other problem? But they do find that falling back to sleep is difficult. And so what could be going on here? Well, we call this sleep fragmentation. And sleep fragmentation essentially means what it says. The sleep is broken up into pieces. And so you may be able to get to sleep, but when you do get to sleep, you wake up in the middle of the night. There are different sort of ways that we categorize sleep difficulty. We can have difficulty with sleep onset or sleep initiation. And so that's trouble falling asleep. And then there can be trouble with sleep maintenance, which is staying asleep. So falling asleep and staying asleep. And this is a problem with staying asleep. And one of the most common causes for sleep fragmentation or problems with sleep maintenance are a return of off symptoms. If you think about it, you're taking, in most cases, carbidopa-levodopa, dopamine replacement during the day to help control your Parkinson's symptoms. And you may, depending on the person, you may have a set period of time that medicine lasts, after which point it might wear off. Other people don't have that wearing off necessarily. But if you have that wearing off in the middle of the night, that could translate into difficulty turning over in bed or difficulty with stiffness. And even though you're asleep, those symptoms could wake you up if you have a decrease in your mobility. I've occasionally had people tell me that tremor returns and that the tremor wakes them up, although that's not really common. Dystonia or painful toe curling can be a problem. So all of these things can combine to wake someone up. The other thing that we see that can happen with getting to sleep in the first place, difficulty with sleep onset but sometimes maintenance too, is depression. So depression, very common in Parkinson's disease. People can go to bed and just lie there and think of things sort of repetitively in their mind, making it difficulty to fall asleep. And so that can cause difficulty with sleep onset. And then a really under-recognized thing that we should be looking for more is sleep apnea. So sleep apnea, as you're probably aware, is sleep disordered breathing. And that's something that can both interrupt sleep in the middle of the night, or sometimes it doesn't necessarily interrupt sleep, or at least the person themselves sleep, but it may cause a problem with the depth of sleep, and therefore the next day the person is sleepy because they really didn't get good sleep the night before because they were having sleep apnea, their oxygen levels were dropping too low and things like that. So laugh and the world laughs with you, snore and you sleep alone. That's the rule, I guess. So how do we treat this kind of sleep difficulty? Well, when you're having trouble turning over in bed or getting out of bed, one of the things that can be helpful are using sheets that make it easier for you to turn over in bed or get out of bed. And so satin sheets can be a good friend. Um, there are ways, if we're dealing with off symptoms in the middle of the night, we can try to optimize the medications. So there's extended release or controlled release versions of the carbidopa levodopa to take at bedtime to try to prevent the wearing off in the middle of the night. And sometimes that can also help if you're having more off symptoms in the morning. And so that's a strategy. There are other medicines. We try to avoid the typical sleep medicines or kind of sleep medicines for Parkinson's patients can sometimes exacerbate thinking and memory difficulty. They can sometimes cause balance difficulty. So we try to avoid things like Benadryl or even sometimes things like Ambien or Lunesta or things like that. It's not that you can't use those, but they do have a higher risk of side effects in a Parkinson's patient. Some things that we do use sometimes are clonazepam, which can help REM-sleep behavior disorder, which we'll talk about in a little bit. Quetiapine is another medicine that sometimes we'll use for sleep and is usually pretty well tolerated. Or antidepressants like trazodone sometimes can be helpful, or Remeron. Sometimes if we're concerned about the possibility of sleep apnea or sleep disordered breathing, snoring, we'll order a sleep study, and that can help us identify if that's present. If that is, a CPAP can prove amazingly helpful to help reduce sleep difficulty. All right, next, I can't seem to fall asleep because of my legs. There's a feeling as if my skin were crawling, and I have to get up and walk around or move my legs. So this is what we call restless leg syndrome. So restless leg syndrome is the urge to move your leg, generally causing abnormal sensations on the legs. It can be really bothersome. And if that's happening, it's usually happening in the evening or at bedtime. And that really disrupts sleep onset because of this feeling and then the need to kind of get up and walk around. Restless leg syndrome and Parkinson's disease. So you can obviously have restless leg syndrome without having Parkinson's disease. But in Parkinson's disease, it's often an off symptom. So as the levodopa is wearing off, that's when you're more likely to get the restless leg kind of symptoms. And so if we want to treat that, we will often try to optimize the dose of the levodopa, maybe add a dose of the carbidopa levodopa, the Sinemet at nighttime. Sometimes we will add specific RLS medications like the dopamine agonists, pramipexole or ropinirole, or sometimes we'll use GABAergic drugs like gabapentin or pregabalin. Those are all medicines that can help specifically with restless leg symptoms as well. So there's a number of different ways to treat that. All right. What else do we hear in clinics? So sometimes we hear that she sleeps all day and she's up all night. She's got her days and her nights mixed up. So why is that? Excessive daytime sleepiness, or sometimes called hypersomnia, can result from a lot of different possibilities. The medicines can sometimes make you sleepy, and so that's something that a lot of people come in and say, it's definitely my medicine, that's what's making me sleepy, and that is true. Almost all the Parkinson's medicines, and actually pretty much any medicine that you're on, if you read the list of side effects, it's going to include sleepiness. That doesn't mean that the medicine is going to cause sleepiness in every single person, but it is a possibility. I'd say the most of the time, the medicines are not the main culprit or the only culprit, but it is something to be aware of. And sometimes it's pretty clear. Someone takes the medication and immediately afterwards they become sleepy. And then some of the specific Parkinson's medicines, the dopamine agonists, can predispose people to specific sleep attacks. And so these are times when you're talking to someone or you're eating or you're driving and all of a sudden you fall asleep suddenly. That's quite unusual, but can be a side effect of that class of medicine. And so important to talk to your doctor if you're having those kinds of things. But, as I said, medicine is almost never the only cause for sleepiness during the day. There's many other causes. So one of the ways I think about it is you're expending a lot of energy to overcome the slowness and the stiffness that are associated with your Parkinson's disease. And so it's basically work just to get up and move around and walk and be active during the day, which we want you to do. But it's harder for you to do that than in someone who doesn't have Parkinson's disease. So you're spending more energy. And so that could sometimes cause fatigue or maybe even sedation. The other thing that can contribute to sedation or sleepiness during the day or fatigue is depression, which leads to can be part of apathy, where you're just not interested in doing things, and so you sort of withdraw and then you go to sleep because there's nothing better to do. But then you sleep during the day and then you're up all night. And so finding these triggers are important so that we can get you awake and active during the day and sleeping at night. So how do we do that? So sleep hygiene is sort of our term for making sure you're active and awake during the day and sleeping at night. So we want to make sure that when you're in the evening or at nighttime, we want to avoid alcohol, we want to avoid caffeine or lots of fluid intake. Normally, we want you to be really hydrated, of course, but at nighttime, excuse me, we don't want you to drink lots and lots of fluid right before going to bed, because then you're going to wake up in the middle of the night multiple times to have to urinate. So we want you to hydrate a lot during the day, but maybe a little bit less at night. And then you want to consciously avoid naps during the day and try to reestablish a normal sleep-wake cycle. So even if you are sleepy during the day, you want to try to push through and stay awake during the day. Now, this isn't to say that you can never take naps. Obviously, naps are good. But if you are having trouble with sleeping during the night, you want to try to reduce or eliminate the naps if possible. If you are having any of the sleep attacks where you're falling asleep suddenly, that's a pretty serious thing. Obviously, if it's happening when you're driving or something like that, we want to address that. And so if it's related to the dopamine agonist medication, sometimes we might have to reduce the dose or sometimes even stop it. And then sometimes we will use stimulants to help to combat the sleepiness during the day, like modafinil, which is Provigil, or methylphenidate, which is Ritalin. All right. What else do we hear in clinic? So I had someone tell me I dreamed I was being chased, and then I found myself out of bed and spread out on the floor. So this is a description of REM sleep behavior disorder. So REM sleep, or REM stage sleep, is when you're dreaming, okay? And so normally your brain is supposed to inhibit any muscle activity. You're basically paralyzed during REM sleep. However, in REM sleep behavior disorder, or RBD, as you can see here in this video, this is when the brain does not paralyze the body during REM sleep. So if you're dreaming about fighting someone, you're hitting out and fighting them and punching them in their sleep. Or if you're dreaming about running, your feet might be running. And so you're acting out your dreams. And so the vignette I gave earlier, I had a patient tell me that he was fighting an alligator and jumped out of bed to fight the alligator. So it can be really associated with vivid dreams. And it can be sometimes pretty benign, not too big of a problem, but sometimes can be pretty severe. And I have had bed partners get seriously injured. It does seem that there is a association between REM sleep behavior disorder and Parkinson's disease. And so you can have REM sleep behavior disorder outside of Parkinson's disease, just like you can have RLS outside of Parkinson's disease, but it's much higher risk inside it, in someone who has Parkinson's disease. And in fact, there are some studies that have followed people who have REM sleep behavior disorder for years and years. And sometimes these kind of symptoms can precede the development of Parkinson's disease by up to 10, 20, or even 30 years. And so there is a theory out there that REM sleep behavior disorder does not exist in isolation, that if you follow people long enough, they will eventually develop Parkinson's disease. So it might be, we consider it one of the prodromal symptoms of Parkinson's disease. And this is borne out by some of the imaging studies that we can do, where we're imaging dopamine uptake in the brain. And on the left here, we can see sort of normal uptake in the basal ganglia. But you can see in the middle and right side, those are areas where there's decreased dopamine uptake in the brain. And we'd see decreased dopamine uptake in the brain in people with Parkinson's disease, but those scans were actually from people who had REM sleep behavior disorder, but did not have symptoms with Parkinson's disease, at least at that time. Interestingly, there's a lot of popular culture references to REM sleep behavior disorder. So this is a this is an article from the Distinguished Journal of Sleep Medicine, where they analyzed REM sleep behavior disorder in Disney animated films. So let's see if I can get this to play here. And I just realized I'm not sure if the sound comes through for you guys, but essentially, Bruno the dog is dreaming about chasing Lucifer the cat. So Cinderella wakes him up and asks him what he's dreaming about. So you can see this. I've seen this in my dog. When she's dreaming, her legs will go. So hopefully she won't develop Parkinson's disease, though. All right. Another issue that we sometimes get. So maybe someone is getting confused at night, and they're seeing bats coming down from the ceiling to attack them. And so this is part of psychosis, or a problem with the brain's perception of what's real and what's not. And this is something that many people with Parkinson's disease can deal with. It's not an indication that someone is crazy at all. It's an indication of the abnormal connections that are being made in the brain. And in fact, this border between being asleep and being awake is a really common time for what we call illusions or hallucinations to develop. So an illusion is when there is something there, but your brain interprets it as something else. So a pile of laundry on a chair in the corner of your bedroom turns into a person that's sitting there. Whereas a hallucination is when your brain just tells you that there's something there when there's actually nothing there. And so that's still along the same spectrum, but slightly different. And so these hallucinations or illusions, many different causes, but they can be related to how long you've had Parkinson's disease, whether or not you have thinking and memory difficulty with your Parkinson's, and sometimes they can be related to medications. So many people are reluctant to talk to people about hallucinations or illusions because they feel like others are going to think that they're crazy. That's really not the case at all, as I was saying. And if you talk to your provider about what's going on, we can help. We can help figure out, are there medicines that we're taking that we need to change around a little bit, or if these things are scary or bothersome, there are ways to help treat it. So we might eliminate one of the medications. We might add a acetylcholinesterase inhibitor, which are thinking in memory medicines that can help to reduce hallucinations. There's a number of different options that we have to help. All right, well, I hope that this has been a helpful presentation. I've gone over a number of different causes for sleep difficulty in Parkinson's disease. Sleep fragmentation really can help or can cause disruption in a full night's sleep, which will really make Parkinson's symptoms worse the next day. Restless leg is associated with Parkinson's disease, often as an off symptom. The excessive daytime sleepiness can result from medication side effects or poor sleep hygiene, depression, lots of different causes. REM sleep behavior disorder can be dangerous, but it is treatable. And hallucinations or psychosis, they may be more common at night. And so it's important to talk to your doctor about them. And so that was the end of my presentation. I wanted to put it out to questions because I thought that would be the most useful thing, is to talk about what you guys personally are having trouble with. So let me stop sharing my screen. Maybe.
What? If you need your medication.
What?
If you need your medication, ask what I did.
Thank you, Dr. Duker. That was great.
Yeah. I hope that was helpful. What questions do you guys have that I can help to answer or talk about?
If we move our medication, does it make it harder to sleep or easier to sleep? Because I've been on the same medication off and on, for the last 13 years.
I'm sorry, you said if you're on medication, does it make it harder?
Well, I've been on the same medication for 13 years, and I'm now at 4 levodopa cinemat and 4 ecopacitone, and then 2 the one that starts with a C, clonazepam, and basically, if you move it around, because I take it at 2 o'clock in the morning, so my alarm goes off. I have trouble going back to sleep then, and then I get it at 6 o'clock in the morning, and my alarm goes off. And I have trouble getting back to sleep about 35 minutes, and I just stare and lay and look at the ceiling. Now, if you change my medication, will I have trouble going back to sleep, or will I sleep better, or what? I do take naps in the afternoon occasionally. Well,
Okay.
more often.
Yeah, you're absolutely right. So sometimes the timing of the medication can influence sleep, and people who are waking up in the middle of the night to take medication, obviously that's going to disrupt sleep as well. And so finding maybe strategies to lengthen how long the medicine is lasting in between doses could be helpful in a situation like that. Whether maybe a controlled release version of the medication or other things. But yeah, sometimes I try to, generally we try our best to avoid having people to have to wake up in the middle of the night to take the medicine, but sometimes that is unavoidable. But trying to find ways to lengthen how long it's lasting could be helpful in those kind of situations.
Thank you.
Yeah.
Questions, Mary?
Also, in that same vein, maybe, I'm sure you probably get up to go to the bathroom during the night. So maybe you could use that time to take your meds rather than setting an alarm to wake up.
Yeah, that's a great point.
I basically don't get up to go to my medication because I go to number 1 in a urinal. I don't get up from the time I go to bed until the morning.
Because you have fallen.
Gotcha.
But because I've fallen occasionally going to the bathroom.
Okay.
I see a question about taking melatonin at night, and if you take that long term, can that be detrimental? That's a great question. No, melatonin is a really safe medication to take. It's one that kind of mimics, or actually is a neurotransmitter that your brain makes normally, and it helps to regulate the sleep-wake cycle. So, we worry about some sleeping medicines of whether they could be habit-forming. But in general, melatonin is not felt to be one of those. And so taking over-the-counter melatonin, whether it's 1 milligrams or 3 milligrams or 5 milligrams, or sometimes even higher doses up to 10 or 20 milligrams have been used. And that can be really helpful to help regulate your sleep-wake cycle. And taking it long-term should not cause any detrimental effects. Someone else asked about a 20-minute nap a day, if they thought it was a good thing. And yeah, absolutely. I didn't mean to say that you shouldn't nap at all. Naps can be good. But if you are not sleeping well at night and you find that you're napping more during the day, that might be evidence that the sleep-wake cycle is not optimal, and you may want to help work on your sleep hygiene by not napping during the day and instead trying to spend that sleep at nighttime. Let's see, what is the difference between restless leg syndrome and extreme and daily dyskinesia of the legs during the day? Is there treatment for the dyskinesia? Yeah, so, restless leg syndrome or restless leg symptoms are, the difference between that and dyskinesia is RLS is a feeling that you need to move your legs, and then you're moving your legs consciously, usually. Whereas dyskinesia is generally more of an involuntary movements of the legs. So you're not moving them because you feel like they need to be moved. They're just sort of moving on their own. But there can be some overlap, and sometimes the distinction is difficult. The dyskinesia, usually the way I explain it to people is if your dopamine is low, then you're going to have low movement or slow movement, difficulty moving around, stiffness and slowness. And that's Parkinson's disease. And as we replace the dopamine and get the dopamine to a more normal level, then we get the movement to a more normal level, and you can move around easier, and you're less slow and you're less stiff. You have less tremor if you have tremor. And then if there's too much dopamine, there may be too much movement. And that's the dyskinesia or wiggly movements that you might see or experience. And so usually dyskinesia is evidence of high dopamine. That doesn't necessarily mean if you have dyskinesia, we need to lower the dopamine, because typically you need that dopamine so that you're not having the slowness or stiffness or shuffling or risk for falling. But sometimes adjustments can be made there. However, there are different patterns of dyskinesia. And so sometimes in certain situations, people can have dyskinesia at the end of their dose when their meds are wearing off. And that's what we call diphasic dyskinesia. And the reason I bring that up is because usually that sort of wearing off dyskinesia is more in the legs. And so sometimes when we see people who are having dyskinesia more in the legs and just the legs, and it's when their medicine's wearing off, then we try to use ways to try to help with wearing off. Let's see, I've been waking up shaking in the middle of the night. You said that was rare. What can be done to help that? Sure. So that sounds like it might be return of tremor in the middle of the night, which is similar to return of any off symptom in the middle of the night, whether it's slowness or stiffness or things like that. And so in those kind of situations, we're looking to try to bridge that gap better, whether it's giving additional levodopa in a regular release or extended release, at bedtime, or adding other medicines to help with reduce wearing off. Sometimes those can be helpful as well. All right, we have a question. I take a half a dose of Cinemed at night and it helps me sleep. That's awesome. Yeah, so if you wake up in the middle of the night and you feel like your off symptoms, part of what woke you up, you could try taking an additional half tablet of the medicine. Talk with your doctor, make sure that's okay, but that should probably be fine. Had a comment about vivid dreams and running during sleep. Yeah, that's the probably evidence of the dream enactment behavior or REM-sleep behavior disorder. And so, some other things to think about with the REM-sleep behavior disorder, obviously, just simple things like putting a layer of pillows between you and your bed partner can be helpful, or bed rails to make sure that you're not jumping out of bed after the alligator. That can be helpful. So finding ways to make your sleeping space safe can be useful. Melatonin sometimes can be helpful for REM sleep behavior disorder as well, and so that's something to be considered. I think that's all of the chat questions that I saw. What other questions that anyone has? Got a hand up. Go ahead.
Could you talk a little bit about how could we determine if we need to get a sleep study, if we have sleep apnea? What are some of the signs of sleep apnea? Sure.
Yeah, I think we're having a lower and lower threshold to refer people for sleep studies. And so if you're having daytime somnolence or sleepiness during the day, it's very reasonable to do a sleep study because having sleep disordered breathing can sometimes be very subtle, and so you may not notice it. So that's, I think, worth doing. More obvious signs like snoring at night, or if you observe someone having an apnea episode where they're stopping breathing during the middle of the night, those would be obvious symptoms. But even, we're having a lower and lower threshold for referring for it. It's sleep apnea, it affects, wakefulness during the next day, but it also affects your risk of stroke and heart attack. There's other factors that sleep apnea increases your risk for. And so it's important to know if you have that.
Thank you.
Yeah, absolutely. Maureen, anything that you were thinking of that we haven't talked about either in the presentation or the chats or anything like that?
Well, I always tell my patients that I have the same problems they do, but I really have a hard time falling asleep. And when people talk about, no Bluetooth, no blue screen, don't watch TV, all those things, it doesn't help me at all. So for me, melatonin wasn't helpful either, but I have found that I really have to do some deep breathing and, even some meditation, quieting my mind, putting myself in a different place, like on a beach with the waves coming over me, something that you call mindfulness, really, that can help clear your mind a little bit to help you fall asleep.
No, that's a great idea. Do you, Maureen, or anyone use like white noise or anything like that to actually have the waves crashing on the beach sound, or no?
Yeah, I've never done that.
Okay. Yeah, they have.
I did find I could never use a digital clock though. I am very sensitive to light when I sleep. So when I would turn over, the digital clock would wake me up. So I gave that away.
Yeah. Oh, yeah, sometimes it's just a matter of paying attention to your surroundings and finding triggers that are interfering with things. So that's great.
It looks like 2 additional questions have been added to the chat.
Oh, yeah, I see them now. How much sleep time is needed to clear the metabolic waste in the brain? And does the PD brain have more waste? Well, at this point, we don't know, probably. That's what I was saying. The evidence suggests that the glymphatic system, or that sort of waste clearing system, is reduced in Parkinson's disease. And so it's probably more in a Parkinson's brain than someone who doesn't have Parkinson's disease. The question is how much sleep time is needed. I don't think we have the absolute answer for that. Certainly, the sleep doctors suggest that you should get 7 to 8 hours of sleep per night. And I think that's appropriate. It's variable, right? Certainly as we age, you do need less sleep. And so if you're not getting a full 7 hours, is not necessarily a bad thing. Really, I think, trying that as a goal, but don't focus on it or get too worried about it if you don't have that. But in general, 7 to 8 hours. Is it okay to take melatonin if you wake up at 3 a.m. and can't get back to sleep? Absolutely. Yeah, it's almost impossible. Well, I won't say it's impossible, but it's hard to overdose on melatonin. So, you know, it's fine to try that. The advice that I usually give people is if you're having trouble with sleep onset or getting to sleep, falling asleep, to take melatonin like about an hour before you think you're going to go to sleep. So by the time that you're ready to go to sleep, it'll have kicked in. Whereas if you're having trouble staying asleep, where you know you fall asleep fine, but you just don't stay asleep, then you could take melatonin at the time that you do, you know, right when you go to bed to try to help it last through the night. There are, I think, extended release forms of melatonin. I've not really seen much research as to whether that's better than regular release melatonin, but that's another option that could be considered as well.
Some sleep people say to take the melatonin an hour before sleep.
Right. Yeah, that's what I tell people if they're having trouble falling asleep, to take it an hour before sleep. But if they fall asleep fine but have trouble staying asleep, then I usually tell people to take it at bedtime so that, you know, it'll prevent them from waking up. But yeah, I think either way, it's probably reasonable for sure.
Here's another question.
Oh yeah, a great app called Calm that can be helpful. Music, meditation, and short stories that are slowly read. Interesting. That's a great comment. Thank you. I just went for a sleep study. In spite of being off melatonin for 10 days, did not engage in dream enactment that night. How is RBD diagnosed if you are not engaged in dream enactment on the night of the study? Great question. So there is, and from a research basis, there's a series of questionnaires that people go through that help to diagnose sleep behavior problems, including REM sleep behavior disorder. And we found that a single question identifies people that have sleep behavior disorder with probably 98% accuracy, so incredible accuracy. And it really is just, do you ever have dream enactment where you were running or fighting or kicking out at sleep? And almost always this is going to be a bed partner that's telling you that. It's hard for the person themselves to know that unless they wake up and things are all over the place. But yeah, so for official diagnosis of REM sleep behavior disorder, yes, you want it verified on a sleep study. But if you have symptoms of the RBD, that's almost just as good. And you don't need an official sleep study to diagnose it, to treat it.
Can I add to that?
Sure.
My Fitbit has all kind of stuff with the sleep, you know, more information than you want to know sometimes.
Yeah.
But if any, you know, that's another one.
Yeah, Fitbits or Apple Watches or things like that. I think Apple Watches do as well, but they have the sleep stages, and they don't always, I don't know if they always tell you that if you're moving during the night, but I think some of them might. So we may have more ways to diagnose this soon.
I'd like to add, I'm Susan Ullman. I'd like to add, I asked the question about going for the sleep study.
Yeah.
And just a comment, they wake you up there to throw you out at about 5:45 in the morning. And I usually have a lot of REM sleep in the early morning hours. So it seems to me that that's counterproductive to wake someone up so early if you're trying to diagnose REM sleep disorder.
Yeah, no, that's true. I think a lot of people have most of their REM sleep towards the end of their sleeping, and less of it during the beginning. And so the sleep study, it's an artificial environment, and so they try to mimic your normal sleeping as much as possible. But there's really it's, you know, you're in an unfamiliar environment. You're got electrodes on your head and on your body, and so it's not exactly the same, obviously, but it's the best tool that we have anyway right now. I think probably, as we were talking about with wearables and videos and things like that, that's going to actually be even more helpful than.
But they would rather see you.
And in fact, for sleep disordered breathing, one of the ways that we're looking at if someone has breathing trouble is a screening study with just a pulse oximeter, like on your finger or something like that, that you can take home and wear that overnight. And if it documents a drop in the oxygenation of the blood overnight, that's a clue that we might be dealing with sleep disordered breathing or sleep apnea. And then we can bring them in for a sleep study to confirm that. Whereas if it's normal, then probably the risk of sleep apnea in those patients is low.
Dr. Duker, do you find rasagiline, I don't know if I'm saying it right,
Yep.
to be helpful? I've had it prescribed, stopped, prescribed again, and I don't know exactly when I should be taking it or how I should be taking it. And do you find it helpful?
Yeah, so rasagiline is an MAO inhibitor. It's inhibits one of the enzymes that breaks down dopamine. And so its job is to make dopamine last longer, so to help to reduce wearing off. And it also sort of just boosts dopamine a little bit by inhibiting its breakdown. So it keeps it around longer, makes dopamine more available. So it can have a little bit of a beneficial effect on slowness and stiffness and tremor. And so it's a weaker medicine for Parkinson's disease. Obviously, if you want more dopamine, increase the dose of dopamine itself. But it can have its place because it helps to smooth things out a little bit for some people and make it last longer. In terms of when to take it, it's a once-a-day medication usually. So the timing is not crucial. Usually people will take it kind of first thing in the morning to help things last better through the day. And because it's got a 24-hour half-life, it only needs to be taken once a day. So theoretically, it shouldn't matter when you take it. Does it help with sleep? I don't know if that was a question that you had, but I guess theoretically, if you're having wearing off in the middle of the night and the rasagiline helps to reduce that wearing off, maybe it could help with sleep in that way. I don't know.
Thank you. I was having trouble when I took it. I've been taking it around dinner time, just kind of as a booster, because when I took too much cinnamon, I would start getting dyskinesia and symptoms. So I've been taking it at dinner time and then taking half a cinnamon before I go to bed.
Yeah, no, sometimes we use that class of medicine to sort of boost the dopamine a little bit, but not too much to cause side effects and go over the top with dyskinesia or other side effects. So.
Thank you.
Sure.
Well, I think we can wrap this up.
All
Oh,
right.
there's one more.
Oh,
Our vivid dreams.
Our vivid dreams evidence of RBD, benign acts as opposed to combative acts. Yeah, it's a good question. Almost always the dream enactment are associated with more, I don't say violent, but high amplitude movement. But there's probably a spectrum, right? And so vivid dreams, we were talking about this actually in Journal Club just recently. So Iris Lynn, one of our fellows, she had some series of very vivid dreams. And so she got interested in this and looked up a bunch of articles about what is the dream content in Parkinson's disease and how does that affect both dream enactment behavior and just Parkinson's disease in general. And it did seem that people who had sort of violent dreams might have had more, severe Parkinson's disease symptoms than those who had more benign dreams. But I don't know, the studies were pretty small. But yeah, interestingly, is the actual content of the gene, of the dream different from person to person? Absolutely. And it's probably a spectrum. We think maybe people who have sort of just vivid dreams but don't act them out are in a sort of pre-motor phase, whereas people who have vivid dreams and then they are acting them out are in a different phase.
I have one question.
Yeah.
A lot of people I've read on different blogs have tried medicinal marijuana to help them sleep. They say it's very effective. Has any research been done on that?
Yeah, I'm not aware of research specifically on cannabinoids or marijuana or things like that for sleep. It wouldn't surprise me that it could have a beneficial effect for some people. Obviously, it definitely has an anti-anxiety or anxiolytic effect. So that's pretty well accepted. And if that's causing some of the sleep difficulty, reducing that could help with sleep. And so it may be something that could be helpful with sleep. But yeah, research-wise, it's harder to tell.
Okay.
Yeah.
Well, thank you very much. If there's not any more questions, we really appreciate your time today, Dr. Duker.
Of course.
And thank you, everybody, for showing up. That's really, we have a really good group here this morning, and it's nice we didn't have to be in person, right?
Yes.
No, it worked out well, actually. So,
Yeah.
Very well.
Very much.
yeah.
So just to reinforce, you know, if you really are having sleep issues, certainly contact your provider, and don't wait until your next appointment either. Okay, that's what my chart messages are for, and that's what phone calls are for. So give us a call so we can troubleshoot and, you know, try and help you get some better sleep.
Yep.
Because that's what we all need.